Welcome to Pediatric Case Review. Today we'll be discussing coarctation of the aorta in pediatrics. This lecture aims to provide pediatric residents with an introductory overview of this important congenital cardiac condition. We'll explore the pathophysiology, clinical presentation, diagnostic approach, management options, and long-term outcomes through clinical cases. Let's begin with our first case. A 2-day-old neonate presents with poor feeding, tachypnea, and weak femoral pulses. Blood pressure in the right arm is 95/60 millimeters of mercury, and in the leg is 65/45 millimeters of mercury. What is the most likely diagnosis? A. Patent ductus arteriosus. B. Coarctation of the aorta. C. Tetralogy of Fallot. D. Ventricular septal defect. The correct answer is B. Coarctation of the aorta. This condition presents with a blood pressure differential between upper and lower extremities. Weak or absent femoral pulses are a classic finding. Neonates with critical coarctation often present after closure of the ductus arteriosus, which had previously provided blood flow to the descending aorta, bypassing the coarctation site. What is the most common location of aortic coarctation? A. Ascending aorta. B. Transverse arch. C. Juxtaductal region. D. Abdominal aorta. The correct answer is C. The juxtaductal region. Coarctation of the aorta typically occurs just distal to the left subclavian artery, near where the ductus arteriosus connects to the aorta. The narrowing is associated with abnormal ductal tissue that constricts after birth. Coarctations are classified as preductal, juxtaductal, or postductal based on their exact relationship to the ductus arteriosus insertion point. A 4-month-old infant with coarctation of the aorta is most likely to have which associated cardiac defect? A. Bicuspid aortic valve. B. Pulmonary stenosis. C. Tetralogy of Fallot. D. Total anomalous pulmonary venous return. The correct answer is A. Bicuspid aortic valve. This is the most common cardiac defect associated with coarctation of the aorta, present in up to 85% of cases. Other common associations include ventricular septal defect, patent ductus arteriosus, and hypoplastic left heart structures. This constellation of left-sided cardiac abnormalities suggests a developmental issue affecting left heart structures. A 5-year-old child presents with hypertension, headaches, and leg pain with exercise. Physical exam reveals blood pressure in the right arm of 135/85 and in the leg of 95/60. Radiofemoral pulse delay is noted. The most likely diagnosis is A. Essential hypertension. B. Renal artery stenosis. C. Coarctation of the aorta. D. Pheochromocytoma. The correct answer is C. Coarctation of the aorta. This case demonstrates the classic triad of findings: upper extremity hypertension, lower extremity hypotension, and radiofemoral pulse delay. In older children, coarctation often presents with exercise intolerance, leg claudication, and headaches related to hypertension. Unlike infants who present with heart failure, older children with coarctation typically present with symptoms related to chronic obstruction and collateral formation. Which physical examination finding is least likely in a 6-month-old with significant coarctation of the aorta? A. Brachial femoral pulse delay. B. Upper extremity hypertension. C. Diastolic murmur at left sternal border. D. Decreased lower extremity pulses. The correct answer is C. Diastolic murmur at left sternal border. This finding is not characteristic of coarctation. The key physical exam findings in coarctation include pulse discrepancy with weak or absent femoral pulses, blood pressure gradient of greater than 20 millimeters of mercury between upper and lower extremities, and a systolic murmur in the left interscapular area due to turbulent flow through the narrowed segment. A systolic ejection click may be heard if a bicuspid aortic valve is present, which is common with coarctation. A 3-month-old presents with heart failure and diminished femoral pulses. Which initial diagnostic test is most appropriate? A. Cardiac MRI. B. Cardiac catheterization. C. Echocardiography. D. CT angiography. The correct answer is C. Echocardiography. This is the first-line imaging modality for suspected coarctation of the aorta, especially in infants. Echocardiography can visualize the site and severity of aortic narrowing, measure the gradient across the coarctation, identify associated cardiac defects, and assess ventricular function. It is non-invasive, readily available, and does not require sedation or radiation, making it ideal for initial evaluation in pediatric patients. A 14-year-old with repaired coarctation needs follow-up imaging. Which modality provides the best evaluation of the aortic arch and potential collaterals? A. Chest X-ray. B. echocardiography. C. Cardiac MRI. D. Exercise stress test. The correct answer is C. Cardiac MRI. This is considered the gold standard for follow-up imaging after coarctation repair, especially in older children and adolescents. Cardiac MRI provides comprehensive evaluation without radiation exposure. It allows complete visualization of the entire aorta, assessment of collateral vessels, detection of restenosis or aneurysm formation, and evaluation of ventricular function. MRI is particularly valuable for long-term surveillance after repair. Which ECG finding is most commonly associated with uncomplicated coarctation of the aorta in a 3-year-old? A. Right ventricular hypertrophy. B. Left ventricular hypertrophy. C. Right bundle branch block. D. Left atrial enlargement. The correct answer is B. Left ventricular hypertrophy. This finding results from the increased afterload on the left ventricle due to the aortic obstruction. The ECG may show increased left ventricular voltages, STT wave changes, and left axis deviation. However, it's important to note that the ECG may be normal in mild cases of coarctation. The severity and chronicity of the obstruction will determine the degree of ventricular hypertrophy seen on ECG. A 2-week-old presents with severe coarctation and heart failure. Which initial management is most appropriate? A. Immediate surgical repair. B. Prostaglandin E1 infusion and stabilization. C. Balloon angioplasty. D. Beta blocker therapy only. The correct answer is B. Prostaglandin E1 infusion and stabilization. In neonates with critical coarctation presenting with heart failure, the first step is to stabilize the patient. Prostaglandin E1 reopens the ductus arteriosus, providing a temporary bypass of the coarctation and improving blood flow to the lower body. This, along with medical management of heart failure, stabilizes the patient before definitive repair. Once stabilized, surgical repair is typically performed, as balloon angioplasty alone has high recoarctation rates in neonates. Which surgical technique for coarctation repair involves removing the narrowed segment and connecting the two ends directly? A. Patch aortoplasty. B. End-to-end anastomosis. C. Subclavian flap aortoplasty. D. Extended end-to-end anastomosis. The correct answer is B. End-to-end anastomosis. This technique involves excising the narrowed segment and directly connecting the two ends of the aorta. Other surgical approaches include extended end-to-end anastomosis, which also addresses arch hypoplasia, subclavian flap aortoplasty, which uses the left subclavian artery as a patch, and patch aortoplasty, which uses a synthetic patch to enlarge the narrowed area. The choice of technique depends on the patient's anatomy, age, and surgeon preference. A 6-year-old with recurrent coarctation after surgical repair is being considered for catheter-based intervention, which is a contraindication for balloon angioplasty with stent placement. A. Previous end-to-end anastomosis. B. 50% narrowing at coarctation site. C. Small patient size, less than 20 kilograms. D. Upper extremity hypertension. The correct answer is C. Small patient size, less than 20 kilograms. Stent placement is generally reserved for older children and adults because stents don't grow with the patient. In small children, the fixed diameter of the stent would eventually cause relative stenosis as the child grows. Additionally, small vessels increase procedural risks. For recurrent coarctation in smaller children, balloon angioplasty without stent placement may be considered, or repeat surgical intervention if the narrowing is severe. A 15-year-old with repaired coarctation at age 2 presents with severe tearing chest pain. Which complication should be most concerning? A. Recoarctation. B. Aortic aneurysm. C. Endocarditis. D. Stroke. The correct answer is B. Aortic aneurysm. Aneurysm formation occurs in 2 to 20% of patients following coarctation repair and is often located at the repair site. The tearing chest pain described is concerning for possible dissection of an aneurysm, which is a life-threatening emergency. Aneurysms are more common with patch aortoplasty techniques and in patients with associated bicuspid aortic valve or connective tissue disorders. This presentation requires urgent imaging and potential intervention, which is not a recommended component of long-term follow-up for a patient with repaired coarctation. A. Blood pressure monitoring in all 4 extremities. B. Periodic advanced imaging of the aorta. C. Exercise restrictions for all patients. D. Endocarditis prophylaxis for dental procedures. The correct answer is C. Exercise restrictions for all patients. Blanket exercise restrictions are not recommended for all patients after coarctation repair. Exercise recommendations should be individualized based on residual gradient, blood pressure response to exercise, and presence of aneurysms. Also note that answer D is incorrect as well. Routine endocarditis prophylaxis is no longer recommended for repaired coarctation unless there's residual defect adjacent to a prosthetic patch or device. Appropriate follow-up includes regular blood pressure monitoring, echocardiography, and periodic MRI or CT imaging every 3 to 5 years. A 10-year-old with repaired coarctation has persistent hypertension with blood pressure 130/80. Which medication is most appropriate for initial management? A. Hydralazine. B. Beta blocker. C. ACE inhibitor. D. Calcium channel blocker. The correct answer is C. ACE inhibitor. These medications are typically first-line agents for managing hypertension after coarctation repair. ACE inhibitors or angiotensin receptor blockers are preferred because they target the renin-angiotensin system, which is often hyperactive in these patients. Beta blockers are good second-line agents. Before starting antihypertensive medication, it's essential to rule out recoarctation as the cause of hypertension. The blood pressure goal is generally below the 90th percentile for age, sex, and height. A 22-year-old female with history of coarctation repair at age 4 is planning pregnancy. Which statement is true regarding pregnancy after coarctation repair? A. Pregnancy is contraindicated in all patients. B. Risk of aortic dissection is extremely high. C. Pre-pregnancy cardiovascular assessment is recommended. D. All patients require cesarean delivery. The correct answer is C. Pre-pregnancy cardiovascular assessment is recommended. Most women with repaired coarctation tolerate pregnancy well, but pre-pregnancy assessment is essential to evaluate aortic dimensions, ventricular function, and blood pressure control. Pregnancy requires increased surveillance, but vaginal delivery is possible in most cases without significant residual obstruction or aneurysms. The risk of aortic dissection is increased but not extremely high in well-repaired cases without aneurysms. Pregnancy would be high risk in patients with unrepaired coarctation or significant recoarctation. A newborn with coarctation of the aorta also has webbed neck and widely spaced nipples. Which genetic syndrome should be suspected? A. DeGeorge syndrome. B. Turner syndrome. C. Williams syndrome. D. Noonan syndrome. The correct answer is B. Turner syndrome. This syndrome, characterized by a 45X karyotype, is associated with coarctation of the aorta in 15 to 30% of cases. The classic features include webbed neck, shield chest, widely spaced nipples, and lymphedema. Other genetic syndromes associated with congenital heart disease include Williams syndrome, which more commonly presents with supravalvular aortic stenosis, and DeGeorge syndrome, which more commonly presents with tetralogy of Fallot or interrupted aortic arch type B. A 6-month-old underwent successful coarctation repair. At the 5-year follow-up, which finding would be most concerning? A. Bicuspid aortic valve without stenosis. B. Arm-leg blood pressure difference of 5 mm of mercury. C. Arm-leg blood pressure difference of 25 mm of mercury. D. Mild left ventricular hypertrophy. The correct answer is C. Arm-leg blood pressure difference of 25 mm of mercury. A blood pressure gradient greater than 20 mm of mercury between upper and lower extremities suggests significant recoarctation requiring further evaluation with imaging studies. This finding may necessitate reintervention, either via catheter-based techniques or surgery. The other findings, bicuspid aortic valve without stenosis, minimal blood pressure gradient, and mild left ventricular hypertrophy, are common after coarctation repair and require monitoring, but not immediate intervention. To conclude, coarctation of the aorta is an important cause of pediatric hypertension with characteristic blood pressure differences between upper and lower extremities. Treatment options include surgical repair and catheter-based interventions, with the approach tailored to the patient's age, anatomy, and clinical situation. Lifelong follow-up is essential as patients remain at risk for recoarctation, aneurysm formation, and hypertension. Thank you for watching Pediatric Case Review. Please follow our channel for more informative presentations, and feel free to leave any questions in the comments section below.